Good afternoon. So I want to introduce you to our civil society-led monitoring of harm reduction in Europe. And, oh, sorry, I was pointing at the wrong thing. So this is we collect data from our focal points, and this is a network of services organizations providing harm reduction services in different places in Europe. And so these people are really in contact on the ground daily with people who use drugs. Most of them are also part of the community. And so they have a very good overview on policy implementation, so what actually happens on the ground. And why we do this, civil society-led monitoring, is actually to complement other monitoring efforts, for instance, from the EUDA or ECDC. And we do that complementary role by looking at not the national level, but the city level, and not the official policies, but what actually happens, how policies actually play on the ground. And specifically for hepatitis C, that's what I will bring today. We look into the availability, but mostly the accessibility of services that are part of the continuum of care for people who inject drugs. So just to go very briefly on a few results and focusing only on treatment, what we see from our focal points is that although DAA, so the treatment is available in every city that we look at, in 40% of them, which is a lot, there are accessibility restrictions. And I would like to highlight restrictions related to being a person who is currently actively using drugs. So people cannot access DAAs because they are still using a certain substance, or people must be enrolled in OAT treatment to be able to access DAAs. So this, again, is not necessarily the policy of the country, but is what happens on the ground. And most often, that's what is reported to us. This has to do with stigma and discrimination towards people who use drugs. And this stigma and discrimination is reported at several points of care, but most commonly at the specialized points of care. And then I wanted to show you this as well. So this is a comparison that we have of where people can be treated, where people actually, the clients that our focal points see every day, where they actually go for treatment. This is a comparison between 2020 and 2024, and we see that there is a trend, and that care treatment for hepatitis keeps being mostly restricted to specialized settings. So we have been talking a lot about the need to lower the threshold for treatment. We have today learned a lot of great examples of peer-led community work, but still I think this let us know that we are far from reaching that. And so we need to keep fostering these examples that we see today and more examples so we can actually reach people where they are. And I was very fast, so that's great.
Thank you.
Just wanted to say that if you want to know more, you can reach to this QR code. So in the white one, you get to our website, and you can go directly to the monitoring project if you want. You can see all we also monitor other areas, not only hepatitis. And in the black QR code, you can see the program. We have a European Harm Reduction Conference coming in December, where we are going to discuss this. We are also going to discuss peer-led monitoring and other projects, so you're very welcome to join us there.
Thank you. And it's difficult for us to say good words about correlation because we work with you so often, so much. We go to the same, we're going to meet in December. So to say good words about what you do is to say good words about us. So, in a way. But I want to say that it was very, very important that you mentioned, first of all, this evaluation. Okay, we say we do that, but what are the results? Do we do it properly? Do we reach people? And as in correlation, you know very well, and I don't bring anything new to you, all the idea is peer-to-peer. Nothing for us without us. We are. So that's it. Correlation are wonderful. I can't really say more. The questions will come later.
Let's applaud.